Yeah, I'll talk to you about the key papers, I suppose, that we've had published so far. The first one was about statin therapy. So we know that statins are great for reducing cholesterol, but there's lots of preclinical research saying that actually statins are great for radioprotection as well in multiple different organs around the body. There's also some head and neck and lung cancer data suggesting that statins might reduce the risk of having a heart problem after radiotherapy or a carotid artery problem after radiotherapy. So we tested that in the NI heart cohort, and we found that, again, there was an association with statin therapies and reduced levels of cardiotoxicity events after treatment as measured by overall survival. So the other interesting finding was that the greater the dose of statin that you were on, the statin dose intensity, this seemed to correspond to even greater magnitudes of protection in terms of overall survival as an endpoint. The cardiac toxicity acute events like heart attacks and heart failure exacerbations, they weren't very different. So there's still more to learn about that. Secondly, we were really interested in the pulmonary veins, so we give lots of radiation to the pulmonary veins. Often our lung cancer tumours or the nodes are quite near the centre of the chest, and there's an incidental bathing of these pulmonary veins with radiation dose. The cardiologists are really interested in the pulmonary veins because if someone has refractory AF, one of the first sort of things that they'll try after the drugs have failed is to do pulmonary vein isolation, where they'll burn off these pulmonary veins and isolate those electrically from the rest of the heart. So we think the pulmonary veins are really important for causing this arrhythmia AF, and we designed an atlas to sort of systematically and robustly analyze the dose of the pulmonary veins, and we found that when we did do that using our atlas that we developed, that the dose of the pulmonary veins seemed to associate with a higher risk of AF. So we think that probably in the future we'll need to tell patients that if their pulmonary vein dose is looking high, that we need to probably consent them that the risk of atrial fibrillation in the future might be a bit higher than what it would be otherwise. So that was an interesting bit of data. And the third thing is that we had tried to validate the Manchester data about the heart base, the substructure region at the top right side of the heart. There's something about that biologically that means that radiation dose there is more impactful than dose to some other part of the heart. And we found, again, like Manchester, that dose to this heart base region did seem to be significant for overall survival down the line. And what's more, we went one step further and looked at cardiac events like heart attacks, heart failure, and we found that those events were more likely as well when the dose to the heart base region was high. And that hasn't been shown before, so that's quite a novel finding. It sort of validates again what Manchester has been doing. And unlike the Manchester data, we were using individual patient contours, so it's quite an accurate way to assess the heart base dose. So yeah, those are the three main things.